All right, well, hello, everyone. My name is Miranda Dold, and on behalf of the Goldstone Caregiver Center and the Faith Community Nurse Program, I'd like to welcome you all to Sleep and Health, presented by Dr. Jose Mendez. Before we start, I want to first wish all of our veterans and their families a happy Veterans Day. We honor all of those who have served our country. Thank you for your service. It's also important to mention that November is National Family Caregivers Month. We'd like to take a moment to recognize all those who take the time to care for their family members. This day and month are truly dedicated to those who give so much of themselves to benefit the lives of others. Someone who exemplifies dedication and compassion is our speaker, Dr. Jose Mendez. He brings so much not only to this discussion, but also to his practice and the care of his patients every day. Dr. Mendez is a pulmonologist and is board certified by the American Board of Internal Medicine in internal medicine, pulmonary, critical care, and sleep medicine, and has trained at the Mayo Clinic. He treats pulmonary patients ages 18 and over and sleep disorder patients ages 1 and over. His area of expertise includes asthma, COPD, interstitial lung diseases, critical illnesses, and sleep disorders such as sleep apnea, insomnia, and narcolepsy. As the medical director of the Sleep Disorders Center in Danbury and New Milford, Dr. Mendez takes a special interest in providing comprehensive sleep evaluations and treatment for children and adults with complex sleep conditions. If you haven't met Dr. Mendez already, you will experience through this presentation his deep compassion and commitment to his patients, always striving to help people obtain great sleep and ultimately achieve a better quality of life. Dr. Mendez speaks Spanish and also supports many members of the Hispanic community in our area. Today, Dr. Mendez will be discussing the most common sleep disorders, their symptoms, how to treat them, and why adequate sleep is so important to our health. Dr. Mendez, thank you so much for being here today. With that, I'm going to turn the program over to you.
Thank you, Miranda and Liz, and thank you everybody for joining me. It's my pleasure to be here. Thank you for the very nice introduction. Some of that is true. I'll start by just showing what she already said. I'm certified in pulmonary critical care and sleep. I'll be honest, my heart is in sleep medicine. Since I started this, I love doing critical care work, but I really do love the field of sleep medicine, which is a very new field, by the way. I did my training in Argentina initially and trained in internal medicine in a hospital university there, and then came back to Danbury Hospital as a resident. So I know the community, I know the hospital since I was an intern here. So went on to Mayo Clinic, did my fellowship training, spent time for 3 years in pulmonary critical care, and then fell in love with sleep medicine and stayed for an extra year until my wife said, it's enough of training, you need to start working one day. And that's when I moved back to Danbury and started my position here. Very happy ever since. It's been 15 years already directing the sleep center, which has been a pleasure. So without much delay, I'll go into what we're going to discuss today. We're going to talk a little bit about general concepts of sleep, and forgive me if I'm too basic, but the idea is to sort of just give you an introduction of how sleep is generated in our brains and in a way, and how we can manipulate that on our advantage to either enhance our good quality of sleep or make it better if there's something wrong with it. We'll talk about sleep deprivation, which is one of my passions, and more important issues that I want to talk about is obesity and sleep deprivation. And then we'll go into the insomnia world and sleep apnea, which is a very common issue that I see in the community. We'll talk about also COVID and how it affected sleep for many of us, myself included. So let me just give you some basic things about sleep. Sleep is divided in 3 or 4, actually 4 stages. Superficial stages are stages 1 and 2. And where we really rest is on the very deep stage of sleep, which is called stage 3. All of those are called non-REM sleep. And REM sleep is when we dream. This is in 4 cycles through the night, about 90 minutes each. So every 90 minutes, you wake up, you have like a micro arousal and you wake up from your sleep without you even knowing this. And every 90 minutes, you have an opportunity of going through non-REM sleep and, oops, this is recording somehow. Let me just get that up. REM sleep and non-REM sleep. I don't know why this is getting in the way. Let me just, I think it's my dictation system that is doing this. Sorry for that. So REM sleep, oh boy, this is gonna, let's see if I can get rid of it. Hold on 1 second. Sorry for that. Okay. All right. Are you guys seeing this again? You guys seeing the screen? Hope so. Yeah.
Yes.
So I was saying about REM sleep is when we dream and not really rest during REM sleep. That's where we have all those visions and sounds and things. Where we really sleep and rest is during stage 3, which is a very deep part of the non-REM sleep. More importantly, what I want to leave you with is the sense that there are 2 processes that actually regulate our sleep. One is a circadian rhythm process, which is biological, something that you don't have much control over, although you could definitely influence it by how you expose yourself to light and sounds and activity. And it's a circadian rhythm that basically goes over the 24-hour cycle, increasing the chances of you falling asleep as the day goes on. And then again, at night, you fall asleep and then that pressure goes down. The sleep load, it comes from another process that actually, as you get closer to your bedtime, you get more tired and you're more likely to fall asleep. So one is a biological process and the other one is sort of your own fatigue that accumulates through the day until you get to sleep. The brain is very much in charge of that circadian rhythm, and it's seated in a very deep portion of the brain called the suprachiasmatic nuclei. And that determines on the basis of melatonin and light exposure how the circadian rhythm goes. So it's a biological process that we all, humans and animals and plants, everybody has this circadian rhythm. It goes through the day in 24-hour cycle. You go to sleep and then you wake up and then the cycle gets repeated. You could manipulate this and you can influence it on your advantage. And I'll show you how to do it. A good simple way of explaining this is, if you think about it, rubber band, right? And this is from Daniel Busey, who is an expert in sleep medicine and insomnia. Basically, the rubber band extends to the day, so that increases your pressure of sleep. So the way I explain to my patients is, the more you stay awake through the day, it's like extending your rubber band. You have more power to fall asleep at night, right? If you nap during the day, for example, then you will decrease that sleep pressure. So one of my first teaching things when I tell patients I have trouble with insomnia is try not to sleep during the day so you maintain that sleep pressure. This other biological clock of day and night is something that you don't have much to do with. It's just you have to realize that it's in your brain, but you can impact it negatively. Let's say, for example, if you in the evening hours, like around 7 or 8 p.m., you start doing your work in the computer and you start exposing yourself to light from the TV and from the phone and the iPad, that light will suppress your melatonin and will affect this circadian rhythm process, which is biological. So
oh my God.
the learning from this is that, again, you increase your pressure by staying awake more during the day, and at night you avoid exposing yourself in the evening to light. Sleep disorders are very common. About 70 million Americans suffer from them. Some of them don't know it. And 1/3 of them will have insomnia during their entire lives. The concerning part is that 10% of the population may end up having insomnia that lasts more than 6 months, which is the definition of chronic insomnia. And sleep apnea is so common in the community. Almost 25% of the adult population may suffer from sleep apnea. Concerning is the fact that it's associated with hypertension, something we deal with in the clinic as clinicians, but also with your primary care doctor's office. So it's something to talk about. Now, the Academy of Sleep Medicine in 2015 looked at what is it that we need in terms of sleep? And we generally recommend that an adult should at least get 7 hours of sleep. Now, that sounds crazy to you now and say, I never will be able to get 7 hours of sleep, but for health purposes, that is what you should aim at least 7 hours of sleep. There is a huge variability, and you may be absolutely normal if you sleep less than that, but in general, 7 hours of sleep is what's recommended. Now, sleep deprivation is a big topic that I want to talk to you about. Sleep deprivation is perhaps one of the most common sleep disorders we see in the practice. And it has to do with sometimes behavioral things we do, our own doing by overworking or doing things in the evening or doing things what we shouldn't be doing, but it has a lot of health repercussions. And as you can see on this busy slide that I'm not going to go into all details, if you are sleep deprived, you are probably going to have issues with cognition, you're going to have memory problems, you're going to have even worsening psychiatric conditions like depression, anxiety, attention deficit disorder in children. It will affect your immune system, a very important topic here today with COVID. It increases your risk of diabetes and heart disease. Why? Because sleep deprivation, and you will see in the next slide, is actively associated with our metabolism. So I'm going to walk you through this slide, which seems very complicated, but I'll tell you it's not. And let me show you how sleep deprivation can connect to obesity. So let's say you are sleep deprived. In your body, these two hormones change. Leptin goes down and ghrelin goes up. Ghrelin is the hormone that makes you hungry. Is the hormone that gets released in the brain to tell you need to go to the fridge and grab something to eat. Leptin is the hormone that tells you you had enough. You need to slow down with your eating. So when you're sleep deprived, you get hungrier, you eat more, and you take more calories. And you know, if you don't keep an eye on this, you could get enough calories to be overweight. Also, when you're sleep deprived, you're not sleeping, you are watching TV or you're on your iPad, you're going to probably be snacking on something. You have more opportunity to eat, will also increase your calorie intake and will lead to obesity. There are very good studies showing that the thermoregulation and how we burn calories gets affected by sleep deprivation, and that also reduces your expenditure of calories, which leads to obesity. If you are fatigued, if you're not sleeping, chances are you're going to prefer to be in the couch watching TV rather than exercising or working out. You're going to consume less calories, also leading to obesity. In other words, the message is sleep deprivation by itself, however you get there, even because you have insomnia or you have a sleep condition or because you have what we call a bad sleep habits or sleep hygiene, it will increment your risk of being overweight. So again, if you want to lose weight, you got to work on your sleep. And that's the important part of this. One thing I want to show you is, and this is a slide that you're not going to be able to read the numbers, but I'll walk you through it. These are teenagers. These are about 600 kids. They actually question of what was their bedtimes along their school age from sixth grade all the way to 12th grade. So school starts about the same time. This is the same, but kids go to bed later and later and later, up to about high school when they go to bed no sooner than 12 o'clock. I have a teenager that I can attest to that fact that he goes to bed at 1 or 2 in the morning, even if that is a sleep doctor. So you can see the gap of how many kids, teenagers, adolescents don't have enough sleep. And the crazy part is my son, like many of the other kids in the community, had just had their driver's license, right? If you ask them, about 50% of them will say they have reported to sleep poorly and drive drowsy at least once in their past year, which scares me. I mean, I think a teenager, which is typically at that age, tends to sleep later and later, and they have this what they call delay sleep phase, which is a medical term to saying they have managed to affect the circadian rhythm enough so that they don't feel sleepy in the evening and they go to bed later and later and later. They're driving, and that leads to accidents, right? If you look at this is international data of thousands of people, thousands of recording of accidents. Most accidents occurred between the hours of midnight and 6 a.m. So a lot of people driving drowsy at night without getting enough sleep. That's no surprise. If you look at mortality in both men and women, this is everybody. The higher or the taller this bar is, means that you have higher chances of dying. Compared to how many hours you sleep, you could see that The perfect sweet spot appears to be about 7 hours. That's the lowest or the lowest or the shortest bars. So the highest bars are in people that sleep less than 3 hours or people that sleep more than 10 hours. Both of those extremes seem to be bad, right? If you don't sleep enough or if you sleep too much. People would say, well, if you say sleep is so good, how come sleeping more is bad? Well, it appears that this group of people are people that have some sort of a sleep disorder. Therefore, they are compensating by sleeping longer or being more in bed. So if you are someone who sleeps more than 10 hours, you may want to have a chat with your doctor, or maybe call us and be seen because something may be wrong with your sleep. Some of the classic examples of how sleep can be horrible and a nightmare are examples of, like in these accidents, that have all been traced down to sleep deprivation. Someone along the line in the chain of the investigation was not sleeping enough and led to a major accident. So this is a big deal. So moving on to exercise and sleep, let me tell you a little bit about sleep apnea, because many of you say, well, I snore at night. I have this problem when I feel very tired during the day. Sleep apnea is a very common condition, one of the commonest we see in the practice, where it could affect up to 60 million people. We think about 25% of the adult population has it. Huge problem with money expense in terms of healthcare utilization. It has to do with breathing behind the palate. And I'll explain it to you in a moment, but basically normal breathing in someone in this scheme implies the air goes in through the nose, behind the palate, and goes nicely into your chest, in and out when you sleep. When you sleep and all of these tissues relax, it blocks breathing, collapses, and doesn't allow you to breathe normally. So it affects your sleep. You choke in your sleep, airway makes the sound of the snoring, and that's when you wake up and it affects your sleep. We'll go into more detail. Treated with CPAP, we can do surgery, and we can do mouthpieces. We'll go into some of those in detail. So let me show you a little video here that is a schematic of what I just went through. This is someone sleeping. This is a palate. This is the tongue right here. This is the back of the airway. And you'll see, I'm going to show you first how sleep apnea occurs and why it occurs.
Back of your tongue and throat relax and restrict airflow. If you have sleep apnea, your throat relaxes to the point where it can cut off breathing.
So here you can see that in someone is sleeping on their back, the palate relaxes, blocks the airway, the tongue goes back. So when you sleep, that airway gets collapsed and blocks the breathing. So it doesn't allow you to breathe. What do you do next? You make an effort to breathe, you snort, you make a very loud noise, and that's when the airway gets open again. That interruption happens over and over again through the night, and it leads to many interruptions in your sleep and multiple issues that we'll discuss in more detail. Which ones, for example? If you have sleep apnea, you have but twice the risk of having a stroke, a heart attack, cardiovascular disease, mainly related to hypertension. And if you have atrial fibrillation, it's an arrhythmia that people sometimes have, chances are that it's going to come back if you treated it, or it's going to be more difficult to control if you have sleep apnea that is not being recognized or treated. So here's an MRI of someone who is normal. And you could see this is the brain, this is the nose, this is the tongue, and the normal, nice open airway, versus someone who is overweight. You could see by the fat pad in the back, and a very narrow airway. And this is someone who is actually sleeping right now. So it's in a sleep position, it's a sleep MRI, and you can see how narrow the airway is in someone with OSA. Now, in terms of who has this and how do you get here, obstructive sleep apnea is clearly more common in men, about 3 times more common in men compared to women. And it's also more common as we age. But in women, you got to recognize that some of them present in the clinic with insomnia problems, nightmares, or depression. So snoring may not be the main presentation in women. For women out there, you got to be aware that having insomnia or nightmares may be a sign of you having a sleep apnea. Also, I want to mention that postmenopausal females tend to have an increased auto sleep apnea. So as women get older, they catch up with men a little bit on the severity of OSA. Another big risk factor that is well known to everybody is overweight, right? A BMI more than 30, it seems to be a marker of risk, of severe risk of sleep apnea. And it has to do with fat deposition around the airway and how it kind of collapses the airway. Another important issue is age. As we age, our risk of having sleep apnea increases dramatically, particularly after age 65. So with all that said, let's say, and this is again a busy slide, but I want to simplify it for you. You have issues with obesity and upper airway obstruction, which leads to respiratory instability. So you're sleeping, you are breathing, you're not, you are blocking your breathing. That is the definition of sleep apnea. And all of these host of problems occur. You have low oxygen levels, your vessels, all your vessels, your aorta, and all your vessels get affected, something called endothelial dysfunction. And you have inflammation and metabolic dysregulation, which leads to heart disease, hypertension, and atrial fibrillation, and heart disease end stage. So again, there is a very good, clear association between disruptions in sleep due to obstructive sleep apnea and heart disease. This is a very interesting study that was done, I believe, in Rochester, Minnesota. That was the population. They looked at the death certificate of people that had sudden cardiac deaths, and they found that about 16% of people 16% of deaths occur at night, 30% between the hours of 6 a.m. and noon, and this isn't everybody. When they looked at patients with obstructive sleep apnea, they realized that a lot of more people were dying at night. So they started thinking that there was something about their night times that was abnormal, leading to heart disease and sudden cardiac deaths. And what was found, which is incredible to me, is that in hypertension, for example, 83% of them, or people that have high blood pressure or heart disease, for example, 77% in obesity, 76% in heart disease, a lot of people with all of these issues have sleep apnea. So you can see, for example, if you take atrial fibrillation, almost half of them have obstructive sleep apnea. If you take patients that had a stroke, 63% of them have sleep apnea. If you're a diabetic, you have a 72% of chances of having sleep apnea. So sleep apnea is a very common comorbid condition in all of these conditions, and it makes everything worse. Hypertension, obesity, heart disease, diabetes, and so on. In atrial fibrillation, it's a big one because you go through a great length of effort in controlling your caffeine intake. You're trying to control your medications, your exercise, your overweight, but you sometimes forget that obstructive sleep apnea can lead to AFib and can make it worse, as I said. So talk to your cardiologist about this association. It's a very big expense. Sleep apnea is costly for the country in medical health cost and medical care and studies. $165 billion is calculated. I think this is a little bit too much, but it probably is in the hundreds of billions of dollars. $45 to $80 billion just in comorbidities and issues like stroke and care for patients that suffer from all of these conditions. So how do we get to it? How do we diagnose it? Well, the first one is we ask questions, right? We talk to patients, we sit down, we spend some time, we create like a little score and create a risk assessment. We do home testing, and this is important for you to know. We do a lot of this testing at home right now. And obviously, if things are difficult and we need to really study someone in the sleep center, we'll do an in-lab polysomnography, which is the in-lab sleep testing. So you may say, how do I know if I have sleep apnea? Well, or someone you love has sleep apnea. Well, you will see, if you recognize some of this, somebody has a big neck, has high blood pressure, they snore, and they stop breathing frequently, chances are you have sleep apnea. So those are the kind of situations where you will say you may have to talk to your doctor or talk to us and make an appointment for us to meet you and discuss it. There are some clues that you could get if you wear a wristband. For example, if you have a Fitbit, or if you have one of those health monitors, you may say, well, last night it gave me a reading that I have a very disrupted nighttime, and that could be a sign that you may have an underlying sleep disorder. So I do pay attention to that, and the Academy of Sleep Medicine tells us that it's not a diagnostic tool, but it's a good guide to tell us your sleep may not be adequate. So this is an example of a home sleep study by one of the brands. By the way, I forgot to mention I have no conflict of interest in any of these products. I have nothing to do with any of these companies. But basically, this is someone sleeping at home with this device.
The desire for patients is a conflict of interest
and measures breathing. And you could see, that is relatively non-invasive. I mean, it's not very intrusive, although it does seem that way even with that picture. Now, we do have even more equipment and more technology recently developed. For example, this is a product by Iramar called the WatchPad, which is like a simple wrist watch type device with a finger measurement, and this is all you have. It connects to your cell phone, and with this little sensor that goes in your neck, detects snoring and can detect sleep apnea. So this is all it is. So if you're looking at the future of how we test sleep apnea, this is it. So your sleep study is not very intrusive. You do this at home, connects to your cell phone, and it gives me information about your sleep apnea. This is our sleep center, is located in Ethan Allen in the hotel. If you come for a sleep study or you need one, this is what you're going to see. A bed that looks pretty much like any hotel bed. There's not a lot of equipment, but you will have more wires and more sensors attached to you. Now, when we discuss sleep apnea, we cannot, treatment for sleep apnea, we cannot avoid by talking about CPAP, which is perhaps our main treatment modality. So I'm going to keep going with this video to exemplify to you how CPAP works.
Back of your tongue and throat relax and restrict airflow.
If everyone can please put themselves on mute, that would be great. Thank you.
Breathing. A CPAP machine is a device you wear over your nose. Pumps air in and keeps the back of your throat open.
So CPAP works by just a tight seal, the nose in the mask creates air pressure that goes in the back of the airway, and in a way it's like a stent of air that keeps this from blocking. So that's a simple technology that is very, very effective. It's our main form of treatment. It's been around since 1981, since Dr. Sullivan developed it in Australia, but it's our main standard of care for treatment of sleep apnea. But it's not the only one. We work closely with dentists and have developed this technology called oral appliances, which are mouthpieces, pretty much very small to wear at night. And they basically work by keeping your jaw forward so that the tongue doesn't block the airway in the back when you relax and fall asleep. Even more recent, there is this device that we are now starting to work with closely with Yale and creating our own program. It's called the Inspire procedure. It's a device that is implanted under the skin, almost like a little pacemaker, and a one-day surgery device type of thing. And it's a little cable that goes underneath the skin here and innervates or basically stimulates the glossopharyngeal nerve, which is the nerve that opens up the airway by pulling the tongue forward. It's a device that is implanted. It's not for everybody. There are certain criteria that you have to meet. We're not going to go into detail, but this is the future of the surgical treatment of sleep apnea. And you will not be wearing anything at night. You will not need a CPAP or any machines. So this is something very exciting we're working on right now. So let me go into insomnia, because I know many of you may be more interested about this issue. Now, insomnia is the difficulties that occurs when you can't fall asleep or stay asleep despite having the opportunity to fall asleep, and you feel horrible during the day. That's basically what it is. It affects 35%. All of us get affected at some point in our lifetime, but 10% of people in the community may have it for months and years, and that's the group that I see in the clinic. Affects females more than males. Elderly patients with comorbidities and disease get affected more often than patients that are healthy. And it affects every aspect of your life. It reduces medical illnesses, reduces quality of life, increases accident risk, worsens or affects management of psychiatric conditions. So it's a very well-known comorbid association with a lot of psychiatric conditions. We go about this by interviewing our patients for a good half an hour in our initial visit. We do a physical examination and we do a mental health general examination to assess for depression.
Yeah.
And then we obtain some data based on occasionally sleep diaries, which are just recording a piece of paper of your schedule. Sometimes we do sleep studies, but very rarely. So the majority of this is an interview and a talk. We go over the details, what time you go to bed, what time you get up, what's your sleep routine. We discuss your habits, how much coffee you take, how much alcohol, if you smoke. We talk about family history. So it's a very in-depth discussion with patients before we can get to the diagnosis and treatment. Now, I'm going to start by showing you this bar graph, which explains why patients end up having insomnia. And I think it's worth spending a little time on this. Let's say you have a particular predisposing genetic. Let's say you come from a family of type A personality, very anxious type of person. So you have a baseline predisposition. You add something called a precipitating issue, let's say COVID, for example, as an example. So COVID came in, hit us all really hard. Everybody got anxious. So you add to your baseline anxiety, COVID. And now you went through the insomnia threshold and you develop insomnia. Now you can't sleep anymore. So what do? You start grasping for stuff. You start staying up later in bed. You start reading and seeing what can I do. You start taking medications on your own. Everybody gives you a piece of advice. So you have these perpetuating issues that people tries to develop, trying to compensate for the problem. Now, time goes by, let's say now, COVID got better, but then you still remain with those bad habits, and in addition to having your baseline predisposition that puts you over this insomnia threshold and keeps the problem going. It's almost like a self-perpetuating issue. So what are those predisposing factors? Let's say if you're a light sleeper, if you're someone very stressful and anxious, you have a particular personality, that will qualify for that. What are the precipitants? Let's say change in jobs, a disease, a pandemic, a divorce, moving, death of a loved one, someone ill in the hospital, and that applies to what Miranda does with the care center, being someone in the ICU, someone having a family member there. That creates an acute moment where you just can't sleep. And what are the perpetuating issues that I was referring to? And this is where I come in and I can modify so that we can get you back below the insomnia threshold. And let's say alcohol, napping, for example. A big one is going to bed too early or staying in bed too much. So basically you're extending your bedtime so much, trying to compensate for this, that your bed becomes your workspace, your office, where you do your homework, you eat, you watch TV, and you say, I'm going to stay a little bit longer, trying to compensate. All of those things are what perpetuates your insomnia. So it becomes like a vicious cycle. This is a slide from Andy Tucker, who is a partner of us, worked with us in the past, and he's a psychologist, and created this beautiful picture showing difficulties falling asleep, creating to frustration, creating almost like a physiological activation. You get anxious, you get tachycardia just by looking at the toothbrush sometimes, which in general perpetuates the cycle again into going again to more insomnia. You look at the clock, for example, a big one. In insomniacs, one of the major things is avoiding looking at the time. Let's say you wake up in the middle of the night, it's 2 o'clock, and you look at the clock, it's 2 o'clock. Then you doze off again, and you wake up again, it's 3 a.m. Just the fact that you're looking at that time creates a sensation of anxiety in your body that is exactly the opposite of what you want. So one of the recommendations, very practical, is eliminate the clock from your room. You really should not know what time it is. You should not know what time it is. As long as you know it's dark and you don't need to get up, that's all you need to know, right? So very important details like that. So we go over in therapy over these sleep hygiene recommendations and some specific recommendations that I gave to patients in the practice. And we go into the treatment of this, which is behavioral therapy of insomnia. That's what I want to spend the most time on. What is behavioral therapy? Well, the cognitive part is teaching you stuff, teaching you about your own sleep and your habits and how they could interact for the worse. What are you doing right? What is to improve? What are the opportunities, right? So that's what we discuss in our cognitive session. What does that mean? We talk. Again, we sit down and discuss. I try to educate you and teach you what I know, what has worked for me, what has worked for other patients. What else can you do? You probably work about sleep hygiene, right? We discuss your schedule and how it could affect your sleep. What is your evening relaxation techniques? And what are you doing? Are you meditating? Are you praying? Are you exercising? What is your timing for exercise? We discuss caffeine, alcohol intake, and how it could affect your sleep. Again, all of those details, and it can be very specific for each one. Each person has a different personality and different habit. It could be different, and a single detail like this could make a huge difference in the way you feel about your sleep. So in terms of the components, I'm not going to bore you about all of this. This is all we do, but basically the main ones is the cognitive session, which is the educational part. And then these two ones, what they call sleep restriction and stimulus control, I want to go into a little bit more detail, which are techniques that I use that you could learn and you own, and basically will be the main core treatment of your insomnia. I will also say, what I think about this, that you'll say, what about medications? And I'm sure you're going to have questions about that. medications have a role, but I will tell you that in insomnia, the best way to treat this is by doing these behavioral techniques, or practicing these behavioral techniques are much more effective and free of side effects, and you'll see how effective they are after you practice them. So Arthur Spillman is a physician who worked with us a long time ago, 1980. He developed or described this technique of sleep restriction, which basically means that you should not be spending any time in bed that is not for sleep. You should not be reading, you should not be working, eating, watching TV, listening to music may be okay if it is relaxing to you, but basically the basics of sleep restriction is limiting your bedtime to sleep time and sleep time only. So the moment you are awake, you need to remove yourself from the bed. And that way, by limiting the amount of time you spend in bed and sleeping, it kind of enhances your power of your sleep. Remember the rubber band that I told you. The more you extend your rubber band, the more power you're going to have the more snap you're going to have out of that. So you're going to have more power to fall asleep if you spend most time awake. But if you're in bed all the time, all night, you're going to make that weak and it's not going to be effective. So we prescribe this in an accumulation mode. So we basically say to patients, you go to bed, you're going to bed, let's say at 10 p.m. and you don't sleep until 3 in the morning. So rather than spending all that time awake, why don't you go to bed when you are really sleepy, closer to your full-time sleep time, and you get up the moment you wake up. And it's very painful, it's difficult to do, but if you do it in small increments, you'll see how much better you get after you do it. We provide patients with sleep logs like this, which are kind of our day-to-day communication tool with patients. So they tell us what time they went to bed, what time they got up. And in that way, I can kind of know, that's the only time they need to know, right? Because I told you earlier, they shouldn't be looking at the clock. But they need to know what time they went to bed and what time they got up. In between, they'll give me a sense of how they felt about their sleep. So stimulus control is another technique that I use. This is kind of reinforcing the association between bed sleep. And again, emphasizes the concept of you should not be in bed doing anything other than sleep, because otherwise it will create this loop of anxiety and frustration. So if you are not sleeping, you get out of the bed and you go to a chair, for example, and you start reading close to your bedroom, reading a book. Rather than using an iPad or an iPhone, I usually recommend to read from a regular paper book with a very dim light. And when you are falling asleep on the book, then you get back to your bed. And if you wake up again, you shouldn't be in bed. You shouldn't be in bed. You should get up on the chair. Again, I'm going to show you this quick video here, but we say in sleep medicine, if you sleep, bed is only for sleep or sex. Otherwise, you shouldn't be there. Just create your room and your bed for only those two things. Don't eat, don't exercise, don't do any homework, and people does all sort of things, meditation and things in bed. Again, try to limit what you do in bed. Let me see if I have time enough. It's almost close to this. I'm going to skip this video then. So again, stimulus control, out of bed if not sleeping, relaxation techniques, obviously that helps. Meditation and guided imagery, we use that a lot in our practice. Paradoxical intention, let me explain what I mean by that. This is what I tell patients, rather than feeling anxious about sleep, I want you to concentrate on staying awake. It's a very odd thing, but it works. Let's say you go out, you go to bed, you can't sleep. Rather than staying in bed, you go to a chair, you grab a book, and you try to stay awake reading. You force yourself to stay awake. You don't look at the clock, and you'll see how by trying the opposite of what you want to try to do, the brain gets tricked in a way and you fall asleep a little bit easier. Very simple, but it works. I do an abbreviated form of what I just discussed with you, something called brief behavioral treatment of insomnia. This takes less than 3 or 4 sessions, which we go over again, healthy sleep practices, what controls sleep, all of that educates you and helps you understand your own body. And then we go into the meat of the treatment, which we just went over. We discuss exercise, we discuss daily routines and medications. Again, keep your bed only for sleep and sex. And practices that hurt sleep, which are very commonly known: alcohol, caffeine, concerns, and worry. One of the techniques I tell my patients is the worry technique, which is a very interesting technique where you will set aside part of your evening rather than using your nighttime to worry about something. So you said, I'm going to take, let's say 7 p.m. is a downtime, is the time my kids are done with school and homework and everything. I sit down in a desk, I grab a piece of paper and I start, let my mind wander and let my worries come into me, and I write them down, and I write like a little discussion of what I'll be doing about them and decide. So when you do get those, what we call intrusive thoughts, that's the medical term of worries that come at night, you'll say, well, I already have time for that tomorrow, so I'll book it on my next schedule for the next worry time. So we talk about this reduction of time in bed. That's very important. Don't go to bed unless you are really sleepy, and don't stay in bed if you're not sleeping. Those are the main messages. If nothing else you want to remember, this is all you need to know about how you manage your insomnia. So the idea is the opposite of you would think. So if you're sleeping soundly, you could go to bed and sleep a little bit longer. But if you're not sleeping, you decrease your time in bed. So you're not in bed if you're not sleeping. So if you have bad insomnia, you should not be in the bed having insomnia. Does it make any sense? So let me tell you about COVID insomnia, and with that I'll close so you have all the chances to answer all the questions that you have. In the US, after the epidemic of COVID, the Academy of Sleep Medicine created this questionnaire or phone calls. I think this was done as a phone call survey, and 2,000 people in the US were questioned and asked about insomnia. And interesting enough, about half of them, 56% of Americans, had insomnia related to COVID. So that's not surprising, right? What was a little surprising and interesting to me particularly is that the majority of the people that responded that they have sleep issues lived in the Northeast. And we still don't know why that is. This is leading to more research in the academy, but it's interesting to see how the Northeast got hit, particularly not only with COVID in New York, but also with the consequences of COVID in our sleep and our insomnia. So it's a very puzzling issue that I think reflects what we see in the community in our practices as physicians and sleep doctors. We see a lot of patients that are having trouble sleeping just basically because of COVID. So with that, I'll close. I have my phone number listed there. That's my office phone number and my work email. And I think Miranda will post that for you. And I will leave the forum open for questions. Thank you.
Thank you so much, Dr. Mendez. You covered a lot of information, and I certainly encourage anyone who has a question to please put it in the chat. There was one comment that I saw and a question already. The comment was from Carol. She said, sleep restriction therapy guided by Katie Noonan saved my life years ago, and I still do it. So that's one thing that has worked well.
Yep. Yep. Can you repeat that again for me? I'm trying to read this. Oh, sleep restriction therapy. Got it. Okay. Save my life. Yes. So I agree with you. I mean, I think, one of the things that I see a lot of is this emphasis in the media and the news and stuff and commercials about medications, but behavioral techniques like sleep restriction and stimulus control is actually extremely more powerful than any medication you can take. Now, that doesn't mean that you shouldn't consider medications. I think that medications have their place and it can be done. It can be helpful. We do use them quite often, but it's not the main core form of treatment. And that's something that everybody in the community needs to understand, that the majority of our patients do better just by exercising those simple techniques that I just explained.
Yeah, most definitely. And actually related to that, are there any natural supplements you recommend that may help with sleep?
Yes. So remember I told you about the circadian rhythm and how this cycle between darkness and light is a biological phenomenon that is related to melatonin. If you supplement melatonin is the one supplement that I recommend. Now, when I say melatonin in my office, everybody says, I already tried that, it didn't work. Well, the reason why it didn't work is perhaps because it was taken in the wrong time, and it wasn't taken into account that your own circadian rhythm. So one of the things when I talk to patients and I get from them what their circadian rhythm is, I can tell them when to take the melatonin and what dose. So everyone is a little bit different, but I can tell you that in general, If you are someone who has trouble falling asleep, a good idea would be to take an evening dose of melatonin no later than 7 or 8 p.m., which is usually a lot earlier than what everybody takes the melatonin. Everybody takes the melatonin at the time of bedtime, which is at that time pretty much like nothing. It doesn't do anything. So one of the recommendations we provide in the office is, we get a sense of the circadian rhythm, and then I can tell you when to use melatonin to make it more effective. But in general, evening doses of melatonin are very helpful.
Thank you. Another question is, can Inspire be used in a patient with a pacemaker?
Good question. Yes. No, the answer is probably not a good idea, because if you have a pacemaker, first of all, probably something led to the pacemaker, a cardiac condition that may not be it may not make you a good candidate for this. The other thing is these devices have limitations as to what MRIs. It's something I forgot to mention, but you cannot get an MRI of the chest, for example. So you can get an MRI of the head, but not of the chest. But in someone with a pacemaker, that would be not an absolute contraindication, but it will make you not a great candidate for this. It's a good question, though.
All right. And a question, I know you touched a little bit upon some of the watches and things that we use,
Yeah.
but a question was asked, how reliable is sleep data provided by trackers like Fitbit?
Yeah, so basically they're not diagnostic of any condition. What they do is they detect movement at night. So restlessness at night usually means either because you're not sleeping or because you are awakening. You're actually being awakened by respiration in the case of sleep apnea, for example. So the way I use it is I use it as an indication of non-restorative sleep and a fragmented sleep. So if I have a bad reading from a Fitbit and it's consistent and it's kind of making sense based on your report that you snore, that you wake up multiple times, you move, that data is useful for me because that tells me that something's wrong with your sleep. I don't use it as a diagnostic necessarily tool, but I use it as maybe let's call it a screening thing. So you can look at your scores of your sleep and you can look at how many times you woke up and say, gosh, I'm waking up a lot more than I realized based on this report. Maybe it's time for me to consider checking this out and having a sleep study or having a conversation with a sleep physician. So yeah, that's a good question too.
That's great. And another question about melatonin. Can you take melatonin too many nights in a row?
No, you can take, I mean, I prescribe melatonin even to children, and it could be a daily supplement. Again, you got to know what time to take it, and it's not a big dose. People tend to up the dose very quickly, but it's because they find it ineffective, not because melatonin is ineffective, but because they're taking it at the wrong time. So you need to know exactly when to take it for you to create that circadian rhythm be your partner, not your enemy kind of thing. So you're working against your own circadian rhythm if you take it in the wrong time. But it's a relatively safe supplement. You can take it every day. So it's not a problem taking it longer than just for the time you have insomnia. In fact, it may take a few weeks before melatonin starts working. So I usually recommend not to quit on it for at least a month before I make an assessment of or when to take it or modifications of dosing.
Great, thank you. Another question, is there a recommended time to wrap up dinner before sleep? And how late can people eat?
So good question. I mean, in general, we say not to eat too close to bedtime. And what does that mean? 2 hours. So a light dinner will be ideal and without alcohol. Every once in a while, but if you drink alcohol every day, you could cut down a little bit. That will be helpful. But late meals will be not a good idea because the body needs time you just need to get your stomach emptied for a better quality sleep. Cool temperatures in the room. And again, eliminating the clock from the room, eliminating the iPad and the phone. Those are the big ones. And again, if you lay in bed and you're looking at the roof and you can't get to sleep, please get out of there, just go to a chair, grab a book, read a magazine until you really fall asleep on the book, and then you get yourself in bed, rather than staying there frustrated looking at the roof. I see a question about dementia. Mm-hmm. Yes, there is a lot of associations between the two. in both ways, in the sense that poor sleep and insomnia can lead to some cognitive impairment, as I told you in some of the slides, but also as the brain suffers from dementia, which is a degenerative process, some of the centers that promote sleep get affected, and patients with dementia tend to have a higher prevalence of insomnia. So yes, there is a strong association with that. I'm looking at also bariatric field, what are the candidates for oral appliances? Good question. So oral appliances are best for patients that have mild to moderate sleep apnea, in particular, those that have very significant differences in, like when they have sleep apnea on their back, for example, that would be the perfect candidate. So if you have a patient that we do a sleep study and we see that their sleep apnea changes dramatically from when they're on their backs versus on the side, and it's in the mild to moderate category, those are the perfect candidates. So mild to moderate sleep apnea with a significant supine, off supine position severity. You have to have good teeth, and you have to have, if you have TMJ, that's not a good idea. Oral appliances are not a good idea. If you suffer from TMJ, it's not good. If you do teeth grinding, that's fine, because the mouthpieces for sleep apnea can treat both. That would be my answer for that. I think that, again, if you keep it for the mild group, mild to moderate, that would be a great population to treat with a dental appliance. They're expensive, though. That's another issue. They're expensive and not well covered by insurance.
And I know that there was another question asking if we could post the sleep log charts so that it could be printed out.
What I can do is I can fax you, Miranda, the one that I have, or put it in an email, and then you could spread it out to whoever needs it. No problem. I'll take care of that.
And on that note too, I hope everyone can see it, but I put in Dr. Mendez's email. I also put in my email because we weren't sure if any emails to Dr. Mendez would be blocked by the hospital. And I am absolutely able to get emails from those outside the hospital. We also put up the Goldstone Caregiver Center websites because we're recording this program and we will post it there. I think sometimes it's hard to take in so much information. So if you ever want to rewatch it, it will be there. There's also a question, can you give a brief description of the difference between BiPAP and the CPAP machines?
Yeah, so the CPAP machine is, CPAP stands for continuous positive pressure, and is a machine that delivers a single pressure at a single level. So you'll see the pressure filling at a single pressure. The BiPAP has 2 levels of pressure. So is for some a little bit more comfortable, and it's not for everybody, has specific indications and regulations from the insurance of who can get it, who cannot. But the difference is on the BiPAP, you have 2 levels of pressure. You have an inspiratory and an expiratory level. So pressure goes up in inspiration and it goes up also in expiration. So you have 2 levels of pressure. CPAP is only a single pressure. It's a continuous pressure that basically creates a stent in the airway. And again, BiPAP is not for everybody. People sometimes assume BiPAP is a better version of the CPAP, but it's not. It has a very specific indications, and there are some patients that do great with it and need it. Others that is actually they create the opposite problem where they just feel too much air is going in. So again, CPAP is the best standard of care for sleep apnea. We do have patients on BiPAP, but those are very specific circumstances we use it for.
Oh. And another question, with a bad night's sleep, is there a way to wake up better versus having trouble with wakefulness or being half awake, half asleep for a while?
Yeah, so I think I know what you're getting at with this. You know, there has been a little bit of information out there in the media of these devices that detect whether you wake up out of non-REM or REM sleep and how that could affect the way you feel in the cycle of the 90-minute cycle, non-REM, REM. I don't particularly believe that's a useful thing. So, I mean, these machines supposedly sense when you're in REM and non-REM, and they will wake you up in the right time kind of thing. I think if you're waking up consistently and you feel like you're drunk, there's something wrong with your sleep. Unless you're not sleeping enough, let's say. You know, if you're someone who is sleep deprived because of work and you sleep in 2 hours, then you can always feel like that. Always feel like jet lag. But if you're waking up consistently every day regardless of the hour, and you may modify a little bit if I wake up in half an hour more, but if you're feeling tired and when you wake up, that's a big, big indication that something's wrong with your sleep. So I don't believe in those timing of wake up being that particularly useful.
Okay, thank you. And another question, can you sleep deeply when dreaming?
Yes, actually, it is a very deep sleep, but it's not a very, what we know now in research and in REM sleep is that it's a very active part of your night. So when you're dreaming, you're burning calories, your heart rate is all over the place, your respiration is very irregular. It's a very metabolically and physiologically active part of your sleep. So in the past, a lot of people say, well, I don't have enough REM sleep. I don't think I dreamed last night. I mean, those are things that are not necessarily true or beneficial for you. So what we do know is that slow wave sleep, which is not when we dream, that's when really the recuperation happens in the brain. That one seems that the neurons and all of that stuff gets refreshed. So REM sleep or dreaming, the dreaming part, that's not particularly, we know we need it. We just don't know. We know we need it. We need about 25% of the night. Everybody does it. Even if you don't remember your dreams, everybody goes into REM. But it's not a particularly restful portion of your night. So a lot of people is focused that and say, yeah, I really think I don't sleep well because I don't have enough REM. That's not necessarily true.
Okay. And then there was a question in the obesity bariatric field. Do you suggest the ESS scale as the best way to screen for sleep apnea? And what score would you suggest to refer to sleep medicine?
Yeah, so ESS is the Epworth Sleepiness Scale. So it's a questionnaire that says, just based on these few questions you answered quickly, what are the chances of you being sleepy beyond normal? A number of 10, a score of 10 is a bad number. So if you have an Epworth score of 10 or more, it's a good idea for you to explore sleep disorders and refer. More valuable than the Epworth is a score called Stop Bang, which is in Cerner. For those of you who are part of the network and are healthcare providers, is part of the Cerner ad hoc questionnaires. I think it is under respiratory. You'll find that. If not, I could provide Miranda with a copy of the questionnaires. It basically says, do you snore nightly? Do you stop breathing? Do you have high blood pressure? What is if you're over 65? If you score if you have a 3 or 4 more of those, yes, then your chances of sleep apnea is tremendously higher. So we use the Fleming questionnaire, we use the Stop Bang questionnaire, and we use the Epworth score. So those are medical questionnaires for you out in the community. Those are questions your doctors will be asking you when you see them, that kind of puts you on the scale of risk. Where are you at in terms of having a sleep disorder? A good question.
Thank you. Does anyone else have any other questions? I'm looking through the chat. I think that Dr. Mendez addressed many of them, if not all of them. Or any other comments? Oh, someone asked where your office is, Dr. Mendez.
Oh, office is in Germantown 33 here in Danbury. And the phone number is 203-739-8330.
Great. Any other questions? All right. Any other closing thoughts, Dr. Mendez?
No, I just want to thank you guys, and I'll be happy. I'm available to you. Miranda will take messages from you. Everybody needs to email me directly, can do that. And I really thank the opportunity. I know it's a lot of stuff I threw at you, so by all means, feel free to call me and ask me questions. You don't need to see me formally, but if you have anything that I can help you with, I'll be more than happy to provide you the information, just direct you in the right way. Miranda will be helping me too, collecting questions, and we'll hope to do this again in the future. Hopefully Miranda will set something up.
Absolutely, we will. So thank you so much. And as you've said, this is a very timely subject. what we have seen is that so many people are struggling with their sleep these days for so many reasons. So thank you for everything. Thank you all for joining us today as well. And we will continue to work with Dr. Mendez and ask him to come back sometime next year. But please do reach out to myself or Dr. Mendez with any questions that you all have at any time. So thank you.
Thank you, everybody. Thank you, Miranda.